I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everybody to another episode of Tell Me Where It Hurts. Today's guest is an emergency room physician with quite an extensive background in healthcare IT. He's kind of a kindred spirit because I'll tell you how I ever got started in the electronic healthcare world. And it was in the process of trying to create an emergency room EMR and talk about a hard thing to do. As a resident, I had several stints in the emergency room, and as a practicing physician, I also did some ER work. So I understand how broad-based it was, but we started out, for people who don't even know this, and probably, Hamad, you probably don't know this either, but remember the Next computer from Stephen Jobs?
It's not something I recall.
Okay. Well, the Next computer was the next big thing, and it was right before they did all the Macintosh stuff.
Oh, okay.
So we bought one of those. It's very expensive, and spent about 3 years of time, money, and effort to create something that never got off the ground. So it was my first trial and failure in the electronic healthcare world, trying to convert, real practice into data. So it's a tough row to hoe. So today's guest is Hamad Husainy. He is a emergency room physician, CMO of PointClickCare. He's had quite an extensive background, several leadership roles, both in management of practices, I would say RCM, as well as electronic healthcare and designing the systems that go along with that. So welcome to the program.
Great to be here. Thank you.
So Hamad, you've been in this quite a while. Could you give us a little background about where you started and how you wound up at PointClickCare?
Yeah, absolutely. So I completed my emergency medicine residency back in 2011, at which point in time I was using a very somewhat archaic homegrown EHR. And then when I took my first job, I transitioned to a more sophisticated EHR that we all would know today in the acute care space. And one thing I recognized was the fact that immediately that these electronic health records were what I would like to call more potential energy rather than kinetic energy. And so they were very, they had all of this opportunity. They stored all of this information, but it was really just for the institution or the partnered institutions together. And so during that time, I actually started using a product called the Emergency Department Information Exchange, which was formerly Collective Medical and now is with PointClickCare. And really, it changed my practice. I went on the record many years ago of saying Zofran ODT and the BiPAP machine and Eddie were the three things that have changed my practice probably the most as an emergency clinician. And so fast forward several years, I embarked on a challenge to bring more transparency to something like physician recruiting, which started a company doing that. And so this theme of transparency, I think, sort of just continued to just sort of stay central in my thought process. And as I started looking more back at technology and looking towards the future of technology, transparency just seemed to be central. And then lastly, I worked on the payer side for a few years, really because I felt like it was a gap in my knowledge, and I felt like there was an opportunity to leverage technology inside the payer space. And the reality that so many payers are using claims data to change and dictate policies and outcomes and payment structures and models for patients just seemed like such an archaic practice. And so that brought me to PointClickCare. I've done some consulting over the years for them and brought me on as their CMO. And it's been a great run so far to really try to bring data real time to the clients that we serve.
Exactly how I got started in this industry in 2004 as a consultant. So I understand that path pretty well. Tell us a little bit about PointClickCare. What you're doing, what's your sweet spot, where do you think you're going?
Yeah, so the role that I play here at PointClickCare is mainly centered around our acute care facilities and our payers. Really, it's how do we bring data that makes sense to the clinician at the bedside, making real-time decisions. And if we expand beyond that, not just the clinician, but the support team, and really all aspects of the medical process, if you will. And so looking at this and thinking about patients coming to the hospital, being able to have real-time data to make informed decisions to reduce unnecessary testing, to reduce unnecessary admissions, fast forward into the hospital process, looking at patients that are discharged into different congregate living settings, whether it be skilled nursing facility, other such facilities, being able to better manage these patients and having a better eye on these patients to recognize earlier potential downfalls that could particularly address the quality of their care, but also their outcomes and their prognosis, effectively readmissions back to the hospital. And then, we can't forget about the payers here, right? The payers are part of the process. They're part of the team. That's how the world of healthcare goes around. And so, again, I talked about transparency a little bit, it's how do we bring more transparency, more data, real time, the quality data that can actually affect both improved expediency, but also quality when it comes to caring for these patients across the care continuum.
Well, interestingly, on that front, the president and the team just announced a $40 billion investment in healthcare IT infrastructure, interoperability standards, things like that. So it looks like there's going to be more funding available to actually start to push the data around the system to make it more useful, make it more obtainable. So let's talk a little bit about that data quality, because that's one of the things that has concerned me over the years, of the quality of the data you get, the amount of the data you get, and how do you actually find anything in it once you get it, which is also a big problem. So tell us a little bit about what your thoughts are on that and how we can make that a little bit better.
Yeah, I think that's becoming more and more. The industry is becoming more and more aware of this every day, every year. It's the classic thing about having data, right? Like it's just a blanket statement, and it really doesn't tell you a lot about the quality. It's sort of like a farmer saying, I have 1 row of corn, or I have 1,000 acres of corn. They're all farmers, right? And so here we are. We're all data providers, but it's really about getting that quality data that's structured, but also unstructured, and being able to utilize technology, AI. We'll talk a little bit about that here shortly. But how do we take data that's structured and unstructured and present it in a structured format for the usability of the client, right? And so whether we're talking about a payer, whether we're talking about a provider, whether we're talking about an ACO, there's different data points that are really important to these folks. And so if, again, being able to optimize the right data at the right time for the right client, I think is the most important thing. And that's optimal, right? And so that's really what we're after here. We recognize the fact that we have clients and partners that are buying data from us that could probably get data from other sources that might be free or what have you. But the reality is that people come back because of the quality of data. And so we're tirelessly looking at how do we improve that constantly. As a clinician, as a fellow clinician, like, to me, we want to make sure we're not providing too much data to the bedside, because too much data is just more noise, right? It's how do I bring that most actionable, necessary data points to my practice where I can make those decisions that are necessary.
So we are going to switch to AI here in just a little bit, and this could lead into that. There's, like you stated, there's really no shortage of data. It's out there. It's either in PDF form or it's on a CDA or whatever. One of my family members just went through a fairly significant health condition that requires 7 clinicians, which all happens to be in the same group, which don't talk to each other. He asked the same questions over and over and over again. She was complaining this morning about that. So let's talk a little bit about the challenges of that, because we do exchange it. There are things flowing around, but it seems as if we put a burden on our providers to try to sort it, get it, use it. We also put a burden on the patients trying to get it to the right people at the right time in the format that they need. So tell us a little bit about what you think the challenges are and how do you convert all this into usable information?
Yeah, I think that the biggest challenge is probably, if we take a few steps out, is just understanding what the real goals for each persona inside the health system is, right? So when we think about the patient, right, it's trying to get the right care for them or their family member, and oftentimes they don't know what the right care is because they're seeking care, right? And so to know what the right information is from a patient standpoint is probably not always a reasonable ask or reasonable expectation. On the clinician side, we may know what the right information is, and we may know what the right questions to ask, and really what the right data we need. But we also recognize that we have time limitations, and we have to be efficient, and we have to do the best we can in the time allotted and with the resources that we have. And so that last point about the resources that we have is where I think we can really come in as a technology conduit to be able to share real-time information in a concise format. One of the things I always say, and I actually heard recently that it was a Colin Powell quote, so I probably have been unfairly taking credit for it until I saw his quote. But we try to create solutions that answer at least 50% of the questions, but not more than 80% of the questions. Because if you're answering more than 80% of your questions, you really have an ineffective tool that's not going to be usable for in the execution of healthcare as a provider. And so a lot of challenges. Obviously, the health system has their own point of view on this, and then obviously the payer has their own point of view. And so, how can we align all of these point of views to a central theme with regards to data and bringing that information to a sort of a standard location and being able to use it appropriately? I think that's sort of the opportunity, but I think it's going to be technology and interoperability that really find that spot. And so I think we're just going through the growing pains today with regards of looking at all of those different organizations and their perspective. But I think ultimately we're going to land in a place where we're a lot more interoperable than we've ever been, and of course the federal dollars help that as well.
So thinking about how AI now has basically been the buzzword and takeover word for everything healthcare IT, at least for the last year and a half. And it seems to me that people are taking AI solutions, and I put solutions in quotes, AI solutions, and throwing it at the wall and seeing what can we do with it. It's like no one's thinking it through. What can we actually incorporate? What's a good use of AI? What's not a good use of AI? So let's talk a little bit about that. Where do you see AI interjecting itself in a meaningful way as opposed to a really hodgepodge conglomeration of stuff?
Yeah, I think that when it comes to AI, the old, or maybe the actual definition of AI is of artificial intelligence. We really look around it here at PointClickCare as an actionable intelligence, right? And so it's not something you can just like deploy and go, hey, now we have AI and it works. And we have examples of that organizationally where we've tried something and it's been good or it's been average, but it needs optimized. And so the point is that these AI is just another tool to use to be able to get to the ultimate outcome of being truly an interoperable society within the healthcare world, right? And so being able to share that data. And so I think commitment is important, commitment and expertise. Having an organization, and I can tell you here at PointClickCare, we're making significant investment in having an underlying intelligence and sort of baseline use case for AI throughout our organization, and that's been a really positive movement for further use cases for AI. And so, again, I think that the opportunity is a lot. I think it's the buzzword right now, and everybody's doing it. But I think you really have to ask yourself the question of what exactly is being used and how is it being deployed and what questions that it's answering. And if you can start getting to that kind of conversation, I think the use cases of AI being super positive will sort of rise to the top, and those that are not so much, I think they'll sort of show themselves.
So not to put you on the spot as a clinician, but one of the things I've been reading lately, and I'm reading it actually quite a bit, is this idea that AI is going to replace a primary care physician. You're just going to put a chat bot out there and they're going to be able to do all of that. And there's a big push for that right now. I had a quote sent to me out by one of my contacts, basically said, well, AI is better than having no doctor at all. And I kind of choked when I heard that, because that's not really true. So I like your opinion on this replacement theory type thing, and it's as opposed to augmentation of practice.
I think at the end of the day, I don't think there's a scenario where they're replaced. Can they augment a practice? Absolutely. Can AI and bots, provide a baseline level of education to a patient, or even recommendations of care? Sure, it can, because it's taught by multiple uses. And so if you were to train working with a physician, potentially you could emulate that physician. But at the end of the day, I think that what patients want from healthcare providers is their opinions, right? I don't think really people pay for just what I know, because if they paid for what I know, they would ask me what I know and the next doctor what they know, and they would always go to the doctor who knows more, right? It's actually what's your world example? Tell me about when's the last time you saw these last 10 patients with a headache that presented in the middle of the night, right? Like, that's what they want to know. And everyone's got a different perspective. And that's why healthcare itself is so interesting. And I find just the way that we're trained is different, right? If you go ask an emergency medicine doctor on how to treat, pelvic pain versus asking an OBGYN versus asking a general surgeon, no one's wrong. You're just getting a different perspective. And I think perspective and opinion are what, in that relationship, in that patient-physician relationship, I think you're going to lose that from AI. And so it's a loaded question. Do I think they'll replace clinicians? I don't. Do I think that they will, people and physicians and clinicians will use AI to augment and even direct and dictate their practice? I do. But I think we're safe to think that we're not going to show up and see a computer screen with no person at the clinic anytime soon.
You can stick your finger in the hole and they'll take a little blood sample and off it goes to wherever. Well, you brought up the concept of training these systems, and the training that has occurred to date, and they've been some focused trainings like in the UK where they've taken all kinds of medical records and tried to force feed an LLM to do what they wanted it to do. So one of the problems, I think, with training an LLM is the quality of the data that it's being fed. So can you talk a little bit about what you think that should look like so it can be better?
I think you're getting something that's very pertinent and on my mind right now, and that is that our medical records, regardless of which EHR you're talking about, are so lengthy and full of information, oftentimes that is not even. I don't want to go as far as saying not accurate, but I would argue that at times it's not accurate, but at times it's very verbose and non-essential to the care of the patient. So to think that, like, if you took my documentation from the hospital that I work at, my ER shifts, and you look at an average chart that might be 4 or 5 pages for a laceration to the finger, you think that, like, it seems like it's so much, and not that we can't, digest that and help direct care in that fashion, but the reality is what it needs is actually a human to help educate it, right? A human to help direct it. And so if you watched what actually happens when I go in to see that finger laceration, I ask about 3 or 4 questions. I check their medical history, and I go in and give them a tetanus shot and sew up their finger. And in 8 minutes, the conversation's over. But if you read my documentation, you would think I was in there for 2 hours. And so we have to be careful, because if we create systems that level the expectation from our documentation, our expectations may become either inaccurate or unrealistic. And so to get to your question, really, the long and short of it is I think it needs to be more human directed and clinician directed rather than documentation directed. And that comes with unstructured data in a lot of ways, whether it's through ambient listening technology or through some form of scribe service.
Interesting about ambient listening right now. That's also a big buzzword where everybody thinks they're going to save a whole gob of time at the end of the day. And I was just talking to I said this before on to other folks, talking to my provider at a local, very large health center, who basically said that it's actually not saved her any time at all. Not one bit. It's just added more burden because of all the verbiage. Just like you said, there's a lot of stuff in there. You'd swear I was in there for 2 hours. I was in there for 10 minutes. So that's what that readout kind of looks like. So when you take all that data together, and what do you think we ought to do to try to either de-silo it or compact it or cleanse it, vet it, whatever word you want to use to really make it good clinical data as opposed to a lot of noise? So talk a little bit about that.
Yeah, I mean, I think at the end of the day, we have to, again, I brought up earlier, how do we get more transparent? And so when it comes to these types of products, one of the things that I've been really fascinated by with AI is the degree at which, dare I say, product humility, and that is where you develop something that you think is going to work, and there's a reality that it might not work at all. It might work 30% of the time, and it might work 80% of the time, but you really don't know until you apply it to a situation. And so as a scientist, that's something we've dealt with our whole careers, right? Like someone in the 1940s, and they go, hey, one person their headache went away, and now you have to go through all of the process to sort of prove it in different locations, different situations and circumstances. And I think that's where we are with AI today, right? It's like, how do we take AI, make theorized solution, and then apply it in real practice? And if we've got more folks willing to put their guard down and allow technology to be tried and failed, tried and succeeded, right? I think that's going to be required of even some of our most sophisticated organizations and institutions, because the reality is that we're entering a new phase of communication of information and communication of very important documents and really prospective decision making. Anyways, I think that's really important, is transparency and sort of the recognition that there's going to be some failures utilizing AI to really address certain clinical quandaries and conundrums.
Well, one of the things, I'll switch the subject just a little bit. One of the things the president was talking about is the money they're going to pour into interoperability to open up pipes, get things running back and forth. He went as far as to say, you're going to have a QR code. It'll come up, you scan your phone, and there's your medical record. You can take it anywhere. By the way, I did mission work in the old Soviet Union back in Kazakhstan, and that's how they did their medical records. It wasn't with a QR code, though. It was a 3x5 piece of index cards. So they did take their medical record everywhere. Yeah. Only wasn't electronic. One of the problems I had when going from one setting to another, they would wind up in the emergency room for whatever reason. They'd go back to the nursing home, or they'd be admitted. Well, if they go back to the nursing home, one of the problems that I would run into almost 100% of the time is, where is the emergency room note? Where is the information that the emergency room did? Thoughts on how do we address that? Because you can transmit information all over the place, but sometimes it's missing, sometimes it's not, sometimes it's incomplete. But we've got to make that better. What's your thoughts on that?
Well, I think part of it goes back into the recognition of what events and what documentation do you need the most percentage of the time. So for using your example of a patient coming from the emergency department back to the skilled nursing facility, is it reasonable to think that 100% of the time the care team would want that note to be available? And so if that's a situation that data should be provided. Also, often in my travels and my experiences of talking with clinicians, I can't tell you how many people that, my brother's an ID doc, for example, and he says, hey, I want to know if they're HIV positive or not. And I'm thinking I'm like, you know what, I appreciate that, but I'm thinking you're probably one of the 5 to 10% of the people that want to know if everybody that they see is HIV positive or not, right? And so it all comes back to perspective. And so having the kind of data that we can surface through acute care facilities back to the skilled nursing facilities, we actually, not to get into specific product talk, but have something called PCC Connect, which allows skilled nursing facilities to view the records from their from the care from the acute care facilities when a patient returns from a hospital or has labs or what have you. And so that was a concern several years ago, and now we provide that to the care team back at the skilled nursing facility at really at no cost. And so being able to provide that, because it fills a care gap, right? It fills a gap that needs to be closed. And so that's really what we spend a lot of time doing, is trying to figure out what exact information is. And it's great being a clinician, but it's also the curse of being a clinician, right? The things that I find important as an emergency physician, my surgical colleagues go, I don't care about that. I want to know if they're on an anticoagulant or not. Like, I don't care about their birth history or whatever it is. And so for me, I have my own biases, but I have to go out and sort of have multiple conversations with a lot of different clinicians, a lot of different personas inside the workforce of healthcare, to be able to really understand what it is that needs to happen every time. And so when we find out those situations, like you mentioned, is how do we be able to provide that? How do we work with the acute care institutions, the payers, the ACOs, the skilled nursing facilities, home health, the ambulatory networks? How do we work with those folks to be able to surface that information every time when we find out that these personas recognize that it's needed all the time?
And interesting you use the word persona, because in AA prompting, that's actually one of the things that they talk about all the time, is personas. Do you think AI could actually help in that situation? Meaning it can analyze the persona that you're looking for, that I am, or what I want, if I'm a cardiologist, if I'm an internal medicine doctor, if I'm an infectious disease physician. Do you think it can have the ability to actually help that, take that large piece of data, cone it down, and give me a view that is more attuned to what I'm looking for?
Absolutely. I think that's the future of how patients present, right? We think about, I'll put my ER hat on again, the triage note, right? Like if every time I see a patient, I'm asking them this standard process of like, what brought you here today? What's your allergies? What are your medications? What are your, if I have a standard way that I document, a standard way that I question, and things that I care about, things that I don't, I think that's the future, is being able to surface that information, before you ask those questions, if it's available. Now, the hard part is back to the quality of data. If I want to know that every patient on an anticoagulant or not, I've got to make sure that I have the quality of data coming in that it was asked either in a medication list or it was documented as a yes, no. I think we have to be careful a little bit when it comes to the documentation and pulling what's documented, because I think over the years there's been a lot of mandates, whether it's we ask things about like patient safety, or whether we ask things about mental health history or whatever, that have been mandated, and it's like in every one of my charts it says, are you suicidal? And I'm like, well, that's not a question I want to ask a 5-year-old kid that comes in with an earache, right? But if you look at my charts, it requires me to ask that of every adult. And so again, it's complicated, but I think the future is optimization. And again, failing a few times before you find that optimal solution for your practice.
So we're kind of coming up on the end of our time here. Is there any other insights or thoughts you'd like our listeners to know?
Yeah, I think electronic health records have been, when I came through residency, I sort of mentioned this, is that it was really this opportunity to what we all thought was going to be interoperability. When I was an ER resident, I thought, man, electronic medical records are going to be the solution for everything. And so I think the opportunity, one phase above that, to really take the information from all of the partners that we have, all of our EHR partners across the spectrum, to be able to really break those silos down, provide the insights necessary, and really just with one thing in mind, and that is how do we take the care of the patient and we improve the care of the patient, improve the quality of the patient, improve the care and the quality and the passion that physicians and the care team have. I think that's something that I've seen over my last 10 years of practice, is just a satisfaction fall off with regards to the healthcare team. And so how do we make their job easier to do better? That sounds super simple and super backwoods, but the reality is that's what we're after here. And we think technology is the conduit, utilizing actionable intelligence and getting better. So yeah, we're excited to address this challenge, and I really appreciate you having me on the show.
Well, I asked this question of all my guests. If there was one thing you could change, just one, in our healthcare IT world, what would that be?
So the one thing I would change is probably centered around the alignment of incentives for everybody that's inside the healthcare world. I think it's really difficult because you have to have a conversation. The conversation has to change depending on who you're talking to. But at the end of the day, the desired outcome is all the same. And so is there a way inside of a healthcare system as complex as ours in the US to be able to get alignment? So I think we're seeing that with value-based care. I think we're seeing that with ACOs. I think we're seeing that inside of risk-bearing entities and what have you. But how does that become sort of more pervasive? How do we then provide insights to be able to drive value for the patient, the clinician, the provider, the payer, and the health system? And so I think that's one thing. If I had a magic wand and I could figure out how to drive alignment across the spectrum, I think that would potentially, oddly enough, shape the IT infrastructure in a way that it would really produce the outcomes that we're hoping for.
That's a great answer. So if someone wants to get a hold of you or learn more about you or PointClickCare, how would they do that?
I'm active on LinkedIn at Hamad Husainy, Hamad.Husainy, and my email is Hamad, Hamad, Husainy at PointClickCare.com.
I mean, thank you so much for being on the program. It's been a pleasure.
Absolutely. Have a great day. Thank you, Dr. Anders.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.